Live now. Good morning, everyone, or good afternoon, according to where you are watching us from. Good night, probably, for someone, and welcome to a new appointment of the live talks organized by ISCAS, the International Society for Coronary Artery Surgery. These are online monthly appointments that are part of the mission of ISCAS and the International Coronary Congress. The concept is not only organizing an annual meeting where we can all rally around, connect, network, and learn about coronary surgery, but also try to organize this monthly appointment where we can spread, promote, and enhance the culture around coronary surgery throughout the years. The motto underneath these events are learning something on a weekend that you can apply on a Monday morning on your next case. And based on this concept and based on this culture, we are here today to discuss about the transit time flow measurement in CABG surgery. Today we will do that. We will do this talk together with Dr. Sigrid Sandner from the Department of Cardiac Surgery, Medical University of Vienna. Hi, Sigrid.
Hi.
Dr. Husam Balkhy from University of Chicago. Hi, Sam. Good morning.
Hi, Gianluca.
Dr. David Taggart from University of Oxford. Dr. Taggart, good morning.
Good morning, Gianluca and colleagues.
Dr. John Puskas is going to join us, as well as Dr. Umberto Benedetto, who has been stuck in the operating room, and hopefully they can join us and they can bring their point of view on this topic as well. Before starting and giving the floor to Dr. David Taggart, I want just to promote for a few minutes the next appointment, the next big meeting that we are organizing in New York City from December 1st to the 3rd of December of this year is the meeting of the International Society of Coronary Artery Surgery, ICC, the International Coronary Congress. A great 3 days for all of us nerds in coronary bypass grafting, passionate about coronary bypass grafting. Come join, submit your abstract. The deadline is approaching soon. And buy your tickets. Flying is becoming expensive, so buy your ticket in advance. Come and join, and will be beautiful to have the opportunity to meet our community, and not only to see all of these views that we make every time that we have this live appointment, but also to network together in live. Have said that, I want to give the floor to Dr. David Taggart. Dr. Taggart has been one of the solid foundation of the International Society of Coronary Artery Surgery and ICC, but also throughout all of his career, always advocating for the concept behind the TTFM. Try to assess the level and the quality of the job that we perform when we are performing a coronary artery bypass grafting. So, Dr. Taggart, tell us a little bit about what's the story behind TTFM. When did it start? When did you start to use it personally? And what is it? How do you use it? What's the basics behind the concept?
Gianluca, thank you very much for that very generous introduction. So I've been interested in this area of quality assessment in coronary artery bypass grafting for over 2 decades now. And I have used different systems, starting with what we used to call the SPY camera, which was fluorescence dye imaging of coronary arteries, and moving on to TTFM, where we showed it was more accurate than the use of dye. But the basic concept is this: if coronary artery bypass grafting is quite a technically challenging operation, whichever way you do it, it depends on maximum use of your skills to get perfect anastomosis. And if you compare what we do in CABG compared to what the cardiologists do, they do a procedure that is very technically much more simple than what we do as a bypass graft. And yet a cardiologist would never put in a stent and not image the final result to check, did I get a good result from this? So if that is necessary for a relatively technically straightforward procedure, you have to ask yourself, should we not be doing the same in coronary artery bypass grafting? And what we have shown, so I won't go into too many details, but we published a large prospective over 1,000 patient follow-up in patients who were undergoing coronary bypass grafting. It's the request study published in JTCVS. And this was done in 7 centers by highly experienced surgeons. And even then, what we showed was that somewhere between 4 to 8% of grafts need revised in the operating room. Now, why is this important using technology like TTFM? If you relied simply on hemodynamic parameters, changes in ECG, changes in wall motion abnormality on an echo, the vast majority of times you have a problem with the graft, they are not shown early in the operating room. But when they do come to light is when you get a call at midnight to say there's a problem with the patient. So the one time you have an opportunity to revise technical intraoperative problems is when you're in the operating room. But unless you image the graft and check, have I got this right? You often will not know until 4 to 8 hours later that there's a problem with your graft. And what we do is highly technically complex. And while some surgeons say, well, look, I don't need to prove I did a great operation, if you're really objective about it, you might think it's very legitimate to say, have I imaged the grafts and did I get it right? And if you do nothing else in coronary artery surgery, apart from checking you have a patent lima to the LAD, because that's the only proven intervention that changes the life expectancy of a patient. So I believe personally, you have a duty to say, if you do nothing else, make sure your patient had a patent lima to the LAD before they leave the operating room.
Very strong statement, and completely agreed, Dr. Taggart. I think the concept here is like try to assess the quality of what we do. We are men of science, we apply science, and part of the scientific approach is always measure and reassess what we do. We do that on valve surgery. Nobody will ever think to do a mitral valve without a transesophageal echocardiogram. We will not be here talking about repair in valve surgery if we would have not implemented the use of intraoperative transesophageal echocardiogram. And that's true for aortic valve surgery, a replacement or a repair. Sigrid, tell me a little bit about your story with transit time flow measurement. Why do you think it's important? How do you implement in your practice? Recently, you've been the second author of a very in-depth review on circulation and this statement about how to use it. Tell us about your journey, your personal experience, and then a little bit about this paper that I suggest everybody to read.
Yeah, so thank you, Gianluca, and also thank you for the opportunity to present this technique to such an interested audience, because I, as David mentioned before, really think that this is one of the major aspects where we can potentially improve our outcomes. And overall, we know that TTFM is only used in approximately 20% of CABG procedures, and this always begs the question is, why is it so underused? And one of the reasons that is frequently given is that there is a lack of evidence, we have to admit that, regarding its prognostic value. And then there is also a lack of standardization on how to actually use TTFM in our everyday practice. And this is the reason why, and I have to give the credit, obviously, to the first author, Dr. Gaudino, who came up with the idea of doing this consensus document involving, a very expert group of people here to contribute with their opinions and their experience. And I don't know what your other slides are going to show, but what we did give are some recommendations on basically how to practically implement the use of TTFM in the operating room. And I just want to give one example. The first consensus statement reads, TTFM should be used in every CABG case. Now, interestingly, this didn't get 100% consensus. I mean, it did reach the threshold, obviously, otherwise it wouldn't have been published. But this is something also that is highly debated, whether you should just be using this when you do very complex graft or a complex anastomosis. But, you know, you also asked how I do it. I do use TTFM in every CABG procedure because you need to be familiar with how to use it and have to be familiar with the readings that come up in different intraoperative settings. And only if you can integrate all the factors, so your, you know, the type of graft that you use, your target vessel stenosis, the quality of your runoff, and then the hemodynamics at that point, and then integrate that with the numbers that you're seeing. And only if you do that on a regular basis are you going to be, in the end, able to make the decision whether this is a good graft, an okay graft, or, you know, not a good graft, where you have to take some kind of action.
Completely agree, Sigrid. Sam, tell us about your journey. You have been exposed to every form of coronary artery bypass grafting. You've been a very heavy off-pump surgeon via sternotomy, and then one of the leader, internationally recognized, and the leader for the total endoscopic coronary bypass grafting, robotic CABG. And it's interesting how you have been always making sure, even in the most advanced and minimal invasive and robotic form, to assess the quality of the work that you were doing. So tell us a little bit about your personal experience with TTFM. What do you think as coronary surgeon, robotic, non-robotic, sternotomy, on pump or off pump? What is your general message that we should send here?
Yeah, no, thank you very much, Gianluca, for the invitation. I think this is an important topic, and I think this is the perfect venue to have this discussion amongst coronary enthusiasts. And I'll tell you just a case in point. I operated on a 73-year-old retired psychiatrist yesterday whose husband is a neurologist. Imagine growing up in that household. And so she came to me complaining of significant coronary disease, or just chest pain, I should say, and was recommended to have a sternotomy. She had 3-vessel disease, a totally occluded right, well collateralized and tight LAD, diffuse disease, and terrible circumflex, and she was adamantly against having a sternotomy. She said, I will never succumb to a sternotomy. I will die with my disease unless you can do something for me. And I'm on this tread of trying to prove that bilateral IMA grafting of as many targets you can get on the left side is as good as single mammary with veins to the other targets. And so she's in our database as that. She's not getting complete revascularization because she really has no targets on the right coronary, and it's well collateralized. So bottom line is we did a multi-vessel TCAB to her with bilateral ITAs. And the first thing her husband asked me, the neurologist, as I'm leaving, he said, how did the postoperative angiogram look? And I said, the flow was great. And so this is a true story. Yesterday, it just literally happened less than 24 hours ago. And I said to him, I said, you are absolutely correct in asking me that, because what we do on the coronaries, on the blood vessels that feed the heart, is extremely important. And we are delinquent in our specialty because vascular surgeons, they do a postoperative angiogram. Orthopedic surgeons, they do a postoperative x-ray to prove that they corrected the fracture in a good way.
And cardiologists,
cardiologists and valve repair surgeons, everybody checks their work. And, you know, I appreciate what Sigrid said about the fact that the guidelines don't require it, but there are some bodies that do require it. The National Health Services in the United Kingdom, correct me if I'm wrong, David, either requires it or reimburses for it. I think the Japanese societies are hot and heavy on trying to get reimbursement for it. So, I mean, I think it's to be very radical, I think it is not a good thing for us as heart surgeons to do work on coronaries and not check what we're doing. It is blasphemous in my mind. And you ask about my journey, Gianluca. I think the reason that I'm very, very big on checking flows and such is because I stepped out of the normal domain of coronary surgery and went from arrested heart to beating heart sternotomy, and then eventually to totally endoscopic, and used different devices. I have a huge experience with anastomotic devices, stapling coronaries, which is extremely, kind of weird to most people. And to be able to do that kind of thing, I think one should absolutely measure flows and make sure that we're not doing things, without control.
That's
sorry.
No, go, David.
Yeah, I was just going to say, if you think of what we're doing, since Dr. Favaloro at the Cleveland Clinic described the systematic use, he wasn't the first to do coronary bypass grafting, but he was the first to describe it systematically. If you look at what we do compared to cardiologists, it's far more technically complex. And a cardiologist would never use a stent without checking his result at the end of that procedure. And yet we often do highly technically complex procedures without really checking what we do. And the second thing that I would say that strikes me as an anomaly is, in the same way, if you look around the world, the use of PCI to CABG ratios, they vary from 25-1 in Japan and Korea to about 4-1 in Europe, 10-1 4-1 in the United Kingdom, 10-1 in Germany, and the same differences in France, Spain. So you have to ask yourself, when we have this, what we think is a standard procedure, why are the ratios so enormously different in which country you're in? And that comes back to what we're talking about today, quality assessment. If you go to Japan, almost every patient in Japan gets quality assessment by TTFM, but they get reimbursed for it. So Japan is not 100% it, but it's probably about 80%. As you go to Germany and Scandinavia, it's about 60-70%. As you go to the UK, it's 10%. If you go to the USA, it's 25%. So you have to ask yourself, with this, what we think is a standard procedure, why are the ratios of different assessment and interventions so enormous? What is driving that difference?
It's very, these are very excellent point. I never really understood either why the assessment is simple. I mean, here we are. I was preparing some videos this morning and just out of my phone. This is from an off pump, and you see we are measuring with two different devices. So we had for a moment in our hospital 2 devices, but the concept is the same. You take a probe and you surround with the probe your graft, and the machine provides you with numbers that you need to be familiar with. We will go through them in very few minutes. But the concept is, it doesn't take much time. It's part of a surgery. It's part of the quality of what we do. And one of the things that I learned from Dr. Balkhy when I was with him was do not take your time. Don't rush through this process. Don't just put a probe and remove it after the first 2 or 3 beats. Wait, learn from it. It's the same concept of promoted by Dr. Taggart and here and Sigrid. Try to figure it out, try to learn. More you use it, more you get acquainted, more you understand the meaning behind all of these numbers. It's like reading EKG or doing anything in life. More you do it, more you get acquainted with it, more you get familiar, more you are better in understanding when it's the time to revise a graft. And if the flow are not good, just revise that graft. You're doing a great service to a patient. That's the most important surgery that patient is going to receive probably in his own life. You should make absolutely 100% certain that what we have done is appropriate. And unfortunately, this concept still doesn't belong in most of us. Sigrid.
Gianluca, what are the 2 things that you have on there? I can't understand. What are the 2 probes that you have?
Well, I have one is a medicine probe, and I'm surrounding with medicine. The other one is Datascope, I think, it's another system that we were having or we were using within our hospital.
I see.
I love this picture because we are not here to promote one specific TTFM, but we are like promoting anyway, even if, because one thing is always cost, but we can discuss about it. But why do you think, Sigrid, why do you think people are still reluctant in using? The adoption is so low. What do you think are the elements that are not allowing most people to use it? Is it really cost-driven? It's sloppiness of surgeons? Is the fact that, of course, everybody does perfect? What is your background? What do you think is happening?
Well, I think that one of the main issues, as I've said before, is that there is no clear, algorithm that leads you to whether you're going to want to revise the graft or not, right? And because ultimately that's the decision it comes down to. And there are no, obviously, I mean, we know, I was going to say there are no clear cutoffs. I mean, we do give recommendations, 20 ml of flow, a PI of 3 or 5 for the right, below which your graft, you can consider it good. But, as I've said before, there are so many factors you have to take into consideration, and there is no one size fits all approach to this. And I think that makes a lot of people reluctant to use it because, I mean, the machine doesn't spit out, revise the graft, right? I mean, I'm hoping that in the future, with more data on flow patterns, there may be some artificial intelligence algorithm derived from, I don't know, thousands, hundreds of thousands of measurements that are correlated, with patency outcomes that will enable us to have such an algorithm. But for now, it's a decision we have to make. And if you're unfamiliar with it, you just, I guess, being skeptical is a large hurdle to pass.
Sam, what do you think?
Yeah, I would say I totally agree with Sigrid that AI has to figure prominently in this in the future. And I gave a talk at last year's STS on the status of coronary surgery in 2028 or something like that, or the status of minimally invasive coronary surgery. I can't remember. But one of the slides that I showed was the potential for artificial intelligence to basically give us that guideline. The minute you put the probe on and the flow is checked and the PI is evaluated, the machine will spit out revise the graft like that. And potentially that might be the thing that moves us into the next level. But in terms of answering your question, Gianluca, about why it's not adopted, I think there's two main reasons. One is lack of information about it, and surgeons are not educated as to the value of it and how really, I've heard a couple of surgeons use the excuse of, I don't even know what the flows mean. Sometimes I get a really high flow, sometimes I get a really low flow, and I have no idea what it means. And that's just lack of information and lack of understanding. And then the second one is, unfortunately, we're a compensation-driven community in some ways. And if it's not compensated, then people won't do it, which is extremely unfortunate and doesn't, speak well of us. But maybe one of the things that will fix that is, the subspecialization in coronary surgery. I don't think that somebody who is a coronary surgeon enthusiast who kind of is interested in coronary surgery would care about the compensation because they're just out to do perfect coronary work. People that adopt all arterial grafting and do all the things that we talk about all the time. And then, I think it's just those two issues that have people, don't understand that it's necessary.
Yeah,
Gianluca, if I could.
Yeah, no, I was telling Dr. Taggart, I will give you the floor, but I found the excuse of saying, like, the machine doesn't give you quite a perfect reading or doesn't give you an answer. At the end, and I know, Sigrid, you are in agreement with me, like, reality is this is just an excuse for most of the surgeons to just try to say, I don't want to put my brains, or I don't want to put my understanding into this. If you think AKG is the same, like 20 years ago, this AKG were a series of tracks that were not exactly clear to anybody, 20, maybe 40 or 50 years ago. Transesophageal is the same. If you don't have someone that can read or can perform properly a transesophageal, the reading of what is your valve or your post-op results of a mitral valve is very different. Can be you can have SAM, you can't, or so. Reality is that we need to learn from us and from what you are doing, and by doing you learn what is the final results of your own work. It's sad to see that there's so much resistance still in adopting novelties in our domain, in our scenario, and that's true for a second arterial conduit, and unfortunately it's true also for testing your own bypass. Dr. Taggart, what is your flow chart? Because we were talking before, how and when do you decide to revise a graft? Which number? This TTFM generally provide you with a flow, a PI, a pulsatility index, a diastolic flow. Which number do you check the most? What is, give us literally your elevator pitch in a simple way. How do you read a TTFM that comes, you are in the operating room? What are your 3-4 things where your eyes are watching? What is your flow charts in your brain?
So thank you. And I think Sigrid illustrated very well. There is a learning curve to understanding TTFM and what the numbers tell you. But my basic premise is very fundamental and very simple, is go with the flow. If your flow is 0 or 5 or 10, whatever you think, you've got a problem with your graft. So if you've got a decent flow, 20, 30, 40, and you still think there may be a possible problem, you can look at other indices like pulsatility index, percentage diastolic flow. But my basic premise, and I told Medicine, but by the way, let me please say this, I have a real conflict of interest here, and I should have said this at the start of the talk, so my apologies to you and the audience, is that I act as an advisor to Medicine, so I should have said that earlier. So I do have a conflict of interest, but I still very strongly believe that if you do an IMA to the LAD that you think is perfect and the flow is 10 mils per minute, you have a problem. Even if there's no change in ECG, hemodynamics, wall motion. So I think the real advantage of this technology is to tell you when there is a definite problem that it's not clinically obvious. You then get into the area where you have more new, as Sam told us, there are more nuanced decisions, you know. So if you've, I'm never happy if the flow in my IMA to the LAD is 15 mils per minute. And this is where I think there's another technology of the Medicine, and again, I've expressed my conflicts of interest. What's very useful, in my opinion, then, is to have an ultrasound probe that allows you to image the anastomosis. I have many cases where we thought we had good flow in the IMA to the LAD, but either the heel or the toe of the graft is blocked, but you can still get good flow in it. So to me, the one thing I like to do is see the flow measurements and then image the IMA to the LAD. Because if I see there is good flow, antegrade and retrograde, I'm very happy. And why is that important? Because you do get situations where you measure a flow, where you may have very high flow in the native vessel that reduces the flow in your TTFM. But the one thing that you need to be sure of, what is the anastomosis like on ultrasound imaging? So if you have a widely patent anastomosis, both at the toe and the heel, you know that you've probably done a pretty good job. But so the two messages I take away from this is basically go with the flow, make sure you have a good flow in your anastomosis, and secondly, appreciate there is a learning curve to using the technology. If your flow is not great, for instance, I've been caught out before where I had a widely patent anastomosis, the flows were not great, and when we imaged the IMA, we found a dissection in the IMA graft on the ultrasound probe. So I don't think there's one simple magical formula to know everything. You need to learn how to use this technology But I still very strongly believe that if you check a patient is leaving the operating room with high flow patency in the internal mammary artery, as I've said before, that is the only intervention that we do that changes the life expectancy of a patient. And therefore, is that worth checking you got it right? Absolutely, yes.
Fantastic. Completely agree. Sigrid, you in this concept of trying to have a flow chart, in the paper that we were citing before, was one of the figures of the decision-making process. And if you want to guide it through it and even add your own taste, add your own process in your operating room when you're doing a bypass, how do you decide time to revise, or as Dr. Taggart was saying, before revising, do some tests, do something else, take a picture of your anastomosis, try to use an ultrasound, and if you don't have Medistim or any other devices, just put one of those sterile condom around an ultrasound probe that you use that your anesthesiologist uses, and try to learn how to take some picture of your graft. So what is your flow chart, and can you give us a little bit of the concept here behind these figures in the paper we cited before?
Yeah. So let me first say I totally agree with David that probably looking at the flow and the PI are the most important measurements that you want to look at TTFM. There are two other measurements, diastolic filling, you've mentioned it, and reverse flow that you can also look at if you connect your machine to an ECG. That is not very popular. It's a cable that runs through the OR. So we usually, I have to confess, only have flow and the pulsatility index. And there's one other point before I go through the chart that I want to make, that you have to have some idea of also what you can expect, right? Because if, for example, you have an LAD CTO, very small lumen vessel, you're probably not going to have, 150 ml of flow, right? So you can be maybe not happy, but you can be okay if you get 25 or 30 ml, right? But if it's a good target, if it's a good graft, and then the flow is like 0 or 5, and the PI is whatever 63, you can't say, you just can't go and say, I think the probe's not working, right? Just because you think you did a good job, right? So you have to make yourself go and look for what's wrong, right? So, and if we want to just look at that chart, it's an algorithm that very simple actually for a very complex decision making process. Obviously, first you're going to want to look at your flow and your PI, and if it's okay, congratulations, you've done a great operation, and hopefully your patient does well. But if your readings are not good, the first step would be to increase the blood pressure that you're measuring at.
Yes.
Because we know it's directly linearly correlated with flow. So if you increase your pressure, but this isn't also, I have to say, 70 millimeters of mercury. We chose that, David, right, as an arbitrary cutoff. There is no solid evidence to support that. This is what the group agreed on. But the important message is that just increase the pressure. And if your flow increases, it's very likely that your graft and your anastomosis is going to be okay, right? And what you can also do are functional tests. So, give inotropic inotropes, or what I never do. I don't know if Sam, you do that, or David, you do. If you snare the vessel proximally to eliminate competitive or potential competitive flow through the native coronary artery, that is one thing that you can do in terms of functional testing. Do you use that?
Yes, absolutely. Absolutely.
Yeah.
Okay. So
I personally, Sigrid, now 2 years ago I would have said to you yes, but I've changed my opinion now, because I have 2 or 3 cases where So the first thing is make sure you've got a mean blood pressure of 80, because the difference in flow in a graft between a mean blood pressure of 60 and a mean blood pressure of 80 is enormous, or can be enormous. But the one place where I found, in my experience, where we were caught out before, where we didn't have good flow in a graft, and I can think of one case, I've shown it at conferences, where we revised the distal anastomosis 3 times because the flow in the IMA to the LAD was not good. And then we finally thought, let's image the IMA graft itself, not just the anastomosis. And we found dissections. So it's very easy to have a dissection in an IMA graft, especially if it's harvested by somebody who's not completely experienced. Sometimes you can see it clinically, you see that bluish swollen appearance. But I have 3 cases of where the graft, the IMA itself, looked absolutely okay. We did not have good flow in the anastomosis to the LAD. So I have one case where we revised it 3 times before we imaged the IMA, and there was a dissection in the body of the IMA. So I think you have to go through the algorithm and think of, if you don't have good flow. So as I said, go with the flow. If the flow is not good, there's usually a problem. You may eventually decide that it's competitive flow or other things. But the other thing I strongly believe now is image the whole length of your IMA. Make sure there's not a dissection in that.
Very good point. Go, Sigrid. Finish your chart. Yeah. Sigrid, if you want to finish your chart or finish your algorithm, you were saying functional test. You don't snare, but do you do any functional test or not really?
Well, I'm personally not a big fan of snaring vessels, but it will eliminate, that I do want to acknowledge, it will eliminate the possibility of competitive flow through the native coronary artery being a reason for abnormal measurements. And then I think, and I've said this multiple times along the last half hour, there are multiple factors that you have to take into consideration. And it says here size and quality of the graft and the target vessel before, and I think we also have a table that gives you multiple reasons why your measurements couldn't be good. There's other reasons. You could have a spastic graft, or twisting or kinking somewhere along the graft, and that goes particularly for vein grafts where you can't see them. So this is the point where you go and check the multiple etiologies that could lead to abnormal measurements. Redoing the anastomosis is the last thing that I do, right? So, on the times that I have frequently actually, a couple of times revised my graft based on TTFM measurements, but it was always right. There was always something wrong. There was either a twisted vein graft. As I've said, that's why I mentioned it, because I actually had that. It twisted. It was a vein graft to the PDA, and it twisted right before it came up over the acute margin of the heart. So, didn't see it, was underneath the clip. So obviously, and I thought I'd, done a good job, done a nice anastomosis, and I had basically no flow and a very high PI. So that's one of the reasons. Or, you have a hematoma along your IMA, and I mean those happen, right? I mean, and it's important that we find them.
Completely agree. Yeah, and I think this concept of integrating the measurement that we assess together with the pre-op angiography, with the condition of the patients, with the quality of the anastomosis we have just done, it's extremely important. Sam, we have some question from Dr. Kasselman. He's watching and he says, comment on difficulties to assess measurements in bad vessels, small diameter, diffuse disease. We have all been there, like meaning how many times you have end up sewing something together to a very calcified LAD, one of those CTO that have completely changing shape, and the lumen is terrible, and now you need to understand that the value and the numbers of your TTFM can be different. How do you integrate this type of information? What is your assessment in difficulties, anastomosis or targets? What do you do? What's your cutoff of range? How do you integrate this type of information?
Yes, absolutely. Hi, Philip. Great to see you this morning or this afternoon, where you are. Gianluca, can I share? I can show you a video of our setup. Let's see, present. Screen. No, it's not working.
You should be able to try now. Try to see if you can.
Okay, so basically the cutoff is very subjective, and I think that what Sigrid said is extremely important in terms of understanding what you have, whether it is the size of your conduit or the size of your target, and most importantly, the degree of your runoff. So if you, for example, are grafting a middle LAD that is 2.5 to 3 millimeters in diameter, the DREAM LAD with a large IMA, and you are able to see that on the preoperative angiogram that this thing goes and feeds collaterals into the posterior wall because of an occluded RCA or occluded circ, you're going to expect 100 cc's. And if I don't get 100 cc's on that case, I'm not happy. I could get 50 and I'm not happy because I expect that thing to flow gangbusters. On the other hand, if I have a distal LAD on a totally occluded LAD that really is just a millimeter in size, and I measure 15 or 20 and my PI is reasonable, and I have, diastolic flow in the, more than 50, 60% range, I'm going to be okay with that. And I'm not going to be terribly worried about having to revise it. And so I think that having the preoperative angiogram in your mind and actually playing in the operating room as you are measuring the flow is extremely important, because I don't think that there is a standardized cutoff for every conduit and every target. And I think that's important for people. That's why you get this comment, well, sometimes the flow is high and sometimes the flow is low, and there's really no consequence from the clinical standpoint. So what does it really mean? And I don't really think I should be checking flows. I think what checking flows does for us, and then this was mentioned earlier in this talk, is that it teaches us about coronary physiology. And I think that is probably one of the most important things that we get out of it as coronary surgeons, is we understand the coronary circulation and what affects it and what doesn't affect it. And the one thing I do want to say about the lack of adoption, one other thing is, I think it is harder for an arrested heart coronary surgeon to check flows and then act on them, because it entails rearresting the heart. And I don't know if the study has been done, David, maybe you be more aware. Is adoption higher in off-pump cases than in arrested heart cases? Because in an off-pump case, if you have poor flow, revising it is not a big deal. You're still off pump. You're just going to put your stabilizer back on and do something. Yeah. Whereas in an arrested heart, it's a big deal. You got to rearrest.
So I agree completely with the comments of both Sigrid and Sam. But two things. So the biggest flow I've ever seen was in one of the trials we were doing, which mandated that the heart was on pump and arrested. The biggest flow I've ever seen on a mammary artery is 440 mils per minute. So you can see these unbelievable flows. But the other thing I've learned in my own mind is that, so in general terms, as I said, go with the flow. So if you've got so what I mean by that is, if you've got a very low flow, 5-10 mils, there's a problem, whatever you think. But I've also seen cases where we've had flows in the IMA of 40 to 50 mils per minute, which we think that looks okay. And then we image the anastomosis and we see there's either a block at the toe, so all the flow is in fact retrograde, or we see there's a block at the heel when all the flow is antegrade. So even when you have what superficially would be acceptable flows, 40 to 50 mils per minute, you can still potentially have a problem in that anastomosis. And my honest take-home message, and I've expressed my conflict of interest working as an advisor for Medicine, my golden rule is make sure you've got a decent flow in the IMA to the LAD, and make sure it's patent at both the toe and the heel, because you can still be caught out.
Absolutely. I think the concept here, and we are getting into the real taking home message. The concept is integrate the information you have before surgery with what you expect. I've done, and I'm very involved too in robotic coronaries, a lot of hybrid, and I can tell you, this minimal invasive allowed me to see a lot of angiogram of my own bypass and allow me to be a better surgeon, because I've seen my own anastomosis. My anastomosis, they look different now because I've seen a lot of angiogram of my own anastomosis. Dr. John Puskas, that I think was up all night with a dissection and has been another of my mentor, always told me that when he started to do off-pump in Atlanta, his previous chairman told him, oh yeah, please start off-pump, but we are going to do an angio on all of the off-pump CABG surgeries done here, right? And instead, whoever does an on-pump, the patient can go home without angiography. And by doing that, he was telling me I had the opportunity to see all of my angio, and every cardiologist and every cardiac surgeon was talking about my anastomosis because they were the only one that were imaged. And somehow I can tell you that even in my own experience with a minimal invasive, I have sometimes decided to do not revise a flow of 25 or 30 in my LAD, or 20, even 20. 25 is a good flow, 30 is a good flow, but 20 and 22, and I have not revised because I knew that that graft was or that LAD was not the best. And then when we went to the angiogram, the lima was perfect, the anastomosis was beautiful, and everything was fine. And as Husam Balkhy just said, I have flow of 30, 35, and I was not happy. That was a wraparound LED CTO.
Yeah.
When I decided to redo an anastomosis, that takes a lot of mental commitment in minimal invasive robotic, like redoing everything. It's just a bad day, but you do it, and then you find always a reason. As Sigrid was saying, you always at the end are happy that you have redone it. You say, well, I've redone it, and then the flow is so much better. So it's absolutely the reality of what we do. Here we are, Dr. John Puskas, alive after the dissection. Well,
everybody's alive after the dissection. There you go.
Good morning, John.
It's important too. Well, how are you, Dr. Puskas? And we are talking about TTFM, as you know, transit time flow measurement. Give us a little bit your story. When did you start? I was citing your story of showing coronaries and doing angio by request of your previous chairman in Atlanta when you started to do off pump. When did you start to use TTFM? Which devices, which elements, and what do you do nowadays?
Well, I have to admit that when I first started doing off-pump bypass in the mid-1990s, we didn't really have these devices at our disposal at Emory. I don't recall the exact year they came on the market, but I think that predated the introduction of the Medistim devices to the market. We used coronary angiography prior to hospital discharge, and we were doing operations, frankly, on patients that were not as sick as our patients are now. They had less diffuse coronary disease. We were in a position where we could be more selective. And frankly, the early postoperative graft patencies by angiography were the 99+%. So when Medistim first came out, I was wondering, is there a need for it in my own practice? But the honest truth is those randomized trial, the surgery versus on-pump versus off-pump trial, the so-called SMART trial, all those cases were done by myself, not my residents. And more, of course, that's not our norm in academic medicine. We want to teach our next generation. And I think of this as an incredibly important training tool for residents to be able to do coronary anastomoses I think we've just absolutely got to provide the patient and frankly, the resident and the teaching professor some assurance, some objective assurance that the patient has been well served by the bypass graft, that the graft is working before we close the chest. Because as I'm sure you've mentioned, it's often the case that a poor graft may be clinically silent in the operating room and not rear its ugly head until later that night, or even later in the hospitalization, or even after hospitalization. Obviously, the patient came to the operating room with that coronary lesion, and if they leave the operating room with the coronary lesion imperfectly bypassed, they may not show a clinical sign that's distinguishable to the patient or to the clinical team. So I think it's an incredibly important objective measure of adequacy of revascularization. And after all, that's what we're doing in coronary surgery. We are revascularizing the heart. We want to know that it is effective. To jump forward to the present day, Gianluca, what I do is I'm sure you recall, we do it in every single case and every single graft. We use the transit time flow meter probe, and whenever that is gives us a number that's or a set of numbers that is disconcerting, we go through a variety of maneuvers. We want to exclude a competitive flow as a reason for a high pulsatility index or a lower than expected flow. Whenever there's a set of numbers that really doesn't jive with what you expect, I heard you comment on the wraparound LED ought to have a really big flow, and if it doesn't, you really should investigate that. Well, we certainly agree with that.
Gianluca, can I push John a little bit more following on? And John, well done for surviving a dissection at night. Not only the patient, but the surgeon is a major achievement these days. It's never, in the middle of the night, it's never easy. But John, let me ask you this, because one of the things that came up earlier in this discussion, one of the things that I made the point that my basic premise is go with the flow. If you've got a good flow, you're okay. But I have several examples of IMA grafts to the LED, which are on flow measurements had good flow. But when we imaged the anastomosis, there was either a block at the toe, when all the flow was in fact retrograde into the LED, or a block at the heel when all the flow was antegrade. And so in my mind, so 2 or 3 years ago, I would have said, if the flow is good, you're okay. But I'm beginning to even revise that concept because what I want to see as a widely patent patulous anastomosis of the lima to the LED. Because as I mentioned earlier in this talk, the only thing we do that is of proven logistic survival benefit to the patient is a widely patent LED to the IMA to the LED. So can I ask you, and I'm not trying to, I just want to get your opinion here. How important is it, apart from having what might be a good flow, to have imaged the anastomosis to make sure it's both patent at the heel and the toe?
Yeah, it's an interesting question, David, and certainly it's clear to all of us that in some scenarios one could have a unidirectional flow out the end of the mammary graft to the LED, or any other graft to any other coronary artery.
Yes.
And only the imaging probe would reveal that in the setting of an adequate, maybe not outstanding, but adequate flow. I have, in all honesty, reserved the use of the imaging probe for concerning flow measures. That's expeditious, and I've thought about it as adequate. And there's certain patterns that are particularly concerning. Obviously, a low flow with a high pulsatility index is really the one that we're most concerned about. And when I see that, I start by looking at the anastomosis with the imaging probe, but I also examine the graft. The flow isn't just through the anastomosis, it's through the entire graft. And we have to know that arterial conduit is not dissected, is not spastic, is not bruised or contused. The same applies for vein grafts. I've actually taken down a vein and found that somewhere in the middle of the conduit, there's scar, presumably previous deep venous thrombosis, where the lumen is almost obliterated in the middle of a vein graft. I've seen the same in radial artery grafts. These are very uncommon events, but it can occur that you have a perfect distal anastomosis and a perfect proximal anastomosis, and somewhere in between, your conduit isn't much of a conduit. The imaging probe can help you find that place where you need to resect part of that conduit and put it into position grafting or fully replace the conduit. So that's for me the beauty of the imaging probe. It can interrogate the entire conduit, making a picture. Now, I will say, and I've said it to our dear friends at Medistim, that I think the imaging probe could be made better. I'd like to see more user-friendly ergonomics to it, and I'd like to see it make higher resolution images. I think AI could even be applied to it to clean up the images that we get with ultrasound. They're not always easy to interpret.
No.
That's something I know that the corporation's working on, and I'm looking forward to trying it out.
I wanted to give some input. We have several questions, and I really wanted to give some feedback to the community who is watching us. We have a lot of viewers in this moment through the free social media platform we are streaming on. Let's start with this one, and I love it. So the concept here is we were saying a lot of people, particularly those that do on pump, they have a problem. If you check your graft when you're coming off pump and everything is done, and now you're not happy, redoing an anastomosis, if you're not facile with off pump, can be challenging. So at that point means you have to rearrest the heart, give cardioplegia, and give it back and redo that anastomosis. And that's maybe one of the major reasons why people don't want to check the flow. So how about if you complete your anastomosis, you are on a rested heart, and then you hook up that proximal graft to a cardioplegia needle, and you provide cardioplegia to a set standard pressure of 100 millimeter of mercury, and you check your flow there. Sigrid, tell us, have you ever done it? What do you think? Does it make sense? What is your concept here? Do you think it's an interesting concept or something to work on?
Well, I wouldn't honestly call this a concept. I do believe in TTFM. That is what I use. I would not check my anastomosis by cardioplegia, honestly, no.
Gianluca, this is how I trained. This is exactly how I trained to do it. John's nodding his head. Us old folk, old timers, this is how we used to check our flows. You basically tell the perfusionist to give down the graft. Now, you can't do the IMA that way because it's attached proximally, naturally, God-given anastomosis there. But for the veins, you can check your flow in the vein graft. So it does have a defect of not inability to check the IMA graft, which is the most important thing you did that day. And it can be a little bit nebulous, and it doesn't give you consistency depending on pressures and whatnot. But it is one methodology to check.
You don't have pulsatility at this point, though. Like your
Correct.
pump,
No pulsatility.
What do you think, Dr. Puskas?
Sam has said exactly what I was going to say. This is precisely how I was trained to do coronary surgery, and I've done this in thousands of cases. And 100 millimeters mercury flow down the cardioplegia medusa or Y or T or whatever device you're using to administer cardioplegia to multiple grafts. It'll push blood into the heart past almost any anastomosis. And it will measure it. The perfusionist can chime up with, how many cc's of flow it is at 100 torr. And it also has the benefit of giving cardioplegia to the heart. Moreover, you can see whether there are leaks in the anastomosis, and you can repair them immediately. So it has some merit, and it costs nothing and takes very little time. I don't think it replaces the use of TTFM at the end of the case. Obviously, it's heparinized. It's before protamine. It's on a still heart. It doesn't assess for the contour of the anastomosis of the graft, the geometry of the graft, or the proximal anastomosis. But it is a test of the conduit between the cardioplegic catheter and the anastomosis. As I said, I've done it thousands of times. It's a huge.
Gianluca, I do most of my cases off pump, and what I've found is that when I give cardioplegia down those off pump cases, it just causes problems.
That's a bad day. No, but the concept here is like, I love the joke, but the concept here is you're using still the probe. You're using TTFM. You're using a probe connected to the graft through which the cardioplegia is going. So it's
this is the TTFM flow on a non-pulsatile cardioplegia.
Correct. That's the concept here. So
I was just asking the perfusionist to tell me what the flow was.
Yeah, I think what he's talking about is the fact that the perfusionist tells you how much you're flowing at that pressure, so as to standardize it.
That's what I understood the question to be.
Yeah,
but the problem with that concept is, as we talked earlier, I told you about a case where I revised an IMA to the LAD 3 times on poor flow, even although the anastomosis looked perfect. Before the penny dropped, and we imaged the whole graft, and we saw a dissection in the body of the IMA. And the problem is, if you give pressurized cardioplegia down the graft, you could still have a dissection in that graft and you won't recognize it because the cardioplegia will override that problem. So so mechanically, the cardioplegia pressurized by the perfusionist could still give you good flow. But in my mind, that does not eliminate, you could still have a problem with that graft.
Very true. Sigrid, I call you back again as first assessment of this other question. Vest is you are really vested in Vest. So tell us a little bit, when you are a Vest, and I want to remind for who is not acquaintance with this concept, is external stenting. Let's call it external stenting of the vein graft, with the concept of improving, promoting the long-term patency of vein graft. How do you assess a flow of a vein that you have just finished to bypass or use as a conduit and is wrapped with your Vest device?
The Vest is a flexible device, so it allows you to extend and compress it, compress it again, even after it's been extended. So you can, if you want to go back and measure your flow, or do a stitch if necessary, like along your graft, you can easily push it back or compress it again to be able to access that part. So having the Vest threaded over the vein graft is absolutely no limitation to assessing your flow.
Dr. Puskas, do you have any feedback? This is the way in which you do it. You just move the Vest, you check, and then you put back the Vest again, and you finalize the Vest. This is how you do it?
Yes. Yeah. You really can't image through the Vest. You've got to sort of image around it. And that is feasible, as Dr. Sandner says.
Fantastic. Last question. This is Sam. Tell us a little bit off pump. Do you think that if you are in off pump, and this concept that you were saying a little bit before, you transition on pump, off pump, minimal invasive TCAB, and you need to make sure that what you're doing is right. And do you think that somehow by advancing your technical skills, you get a little bit more acquainted with this technology, or you are more prone to check your graft to make sure that what you're doing is still excellent care for patients? So
yes, I totally think so. I think that it's a good question, and we alluded to it a little earlier, that it's easier for an off-pump surgeon to check the flow and then make the correction because they're still off-pump, and it really just means putting the stabilizer back on, as compared to an arrested heart surgeon that will need to potentially, if they want to revise the graft, have to go back and arrest the heart. But in addition to all the things that you said, Gianluca, moving from traditional approaches, sternotomy arrested heart, to off-pump, to mini thoracotomy, to totally endoscopic, and using anastomotic devices. There's 2 new anastomotic devices that are coming online, both from the Netherlands. One is called the Octacon, and the other one is the AMT device with the laser. And hopefully we're going to be starting the US feasibility trials for that one, the second one, soon. And when you have something like that, you absolutely have to have TTFM and or patency control. When we did the Seaport trial, and John was the lead author on the Passport trial, both anastomotic devices, distal and proximal, you have to have control to make sure that you're doing a good job and standard of care, and you're not having bad outcomes. So I think it's important as you move through the different modalities of coronary surgery to have to check flows and make sure that you're doing a good job. The one thing that I did want to add real quick to David's comment of go with the flow is, if I were to think, you asked this question early, Gianluca, if I were to think the one thing that makes me stop in my tracks is not necessarily a flow of 15 or 18, because if it correlates with what I see on the angiogram, I'm kind of okay with that. The one thing that makes me stop in my tracks is a PI of 12 or a PI of 22. It doesn't matter what the flow is. Now, normally that's associated with a flow of badness, but you won't get a flow of 100 and a PI of 12. But the thing that makes me like stop and really pay attention, get out of my chair and go to the Medistim thing and say, let me kick it, is it wrong? Is when the PI is too high. And that's the one that really makes me worry, and I would revise those for sure.
Yeah,
if I could make a very quick comment here. So to me, if you've got, as Sam has just said, if you've got a high PI over 5, be very worried. The problem is often with a PI, it's somewhere between 2 and 5, and then you're left kind of thinking, what do I do with this? But the one thing I absolutely genuinely believe is that the one thing you need to do when that patient leaves the operating room is make sure that the IMA to the LAD is patent. If you've used 2 IMAs, even more important. Because the one thing that time has taught me is you can often have a problem with the graft that there are no obvious measures in the operating room. There's no change in hemodynamics, ECG, echo movements. But it's when you get the phone call at 11 o'clock at night, there's a problem. So And as I emphasize again, the one thing we do that changes the life expectancy of a patient, the only proven intervention in cardiovascular medicine that changes the life expectancy of a patient over the long term is having a patent IMA to the LAD. So to me, it's very, very important that when that patient leaves the operating room, you've confirmed that to be the case.
I would say that the thing that stops me in my tracks is if the PI exceeds the flow. That ratio should never exist in nature, and clearly there's a problem there. And I wish I could tell you that I've never had to revise a graft because of that event, but I have. That's usually the one that you can find that you weren't supervising that anastomosis as clearly as or tightly as you thought, and there was a toe problem. Yeah. There is a back wall stitch or something like that. And you have to switch sides and redo that graft yourself and extend it and make a longer anastomosis, cover that territory, exclude that flap or whatever it is. But there's a problem if the PI exceeds the flow.
Completely agree. So I think the amount of messages that we have provided today was huge. The concept here is, one, use TTFM when you're doing a bypass grafting. Get facile, get used to it. More you use it, more you understand this number, more is you are comfortable with it. Second, it's not a huge science. Go with the flow is the second message you should bring home from today's elements. At least check your flow. Check and learn these numbers. And then come a little bit more extra. The extra step is understand your pulsatility index and try to understand how to integrate it with your thing, with the final results. Number 3, start to imagine what the flow will be for that specific bypass by weighting a series of different information: patient characteristic, patient's anatomy, coronary angiography, quality of the graft. And understand, should you redo it or not? A graft is always a big decision. Can the patient sustain a second cardioplegic time? Can that coronaries sustain the fact that you are removing a stitch of it and you are redoing the anastomosis? We have all dealt with very calcified vessel. Better not to touch than to redo it. So this is the third information. Fourth information that you should bring home is, when you have bad flow and high PI, or when you have a combination of the two and you are not sure, takes and imaging is very important. Imaging probe can help and guide you even more in deciding what to do. Imaging comes with a TTFM. Sometimes you can just grab the probe from your anesthesiologist, wrap around something sterile, and start to get facile and start to use these probes and learn how to take pictures of your own anastomosis. Don't leave the operating room without checking the flow of your graft after a coronary artery bypass grafting. Yes, we don't get rewarded from an economical point of view, but we get rewarded by the quality of the cases that we do and by the outcomes of our patients. And with that, guys, I think it's time to wrap around. We are already 20 minutes over our time, but it was important to give some feedback to the community. We had so many questions. A lot of
Gianluca, just to say to you, and really warmest congratulations. Thank you for organizing these fantastic sessions. And they even, I thought I knew a lot about coronary surgery, but I'm still learning from these. And also thank you to our excellent panelists for joining us today. But mainly thank you to you for organizing this. Thank you.
No, thank you so much. We had so many messages, a lot of people watching us from all over the world. So guys, thank you for staying with us and stick with us for so long. Thank you for all of you. Thank you, Dr. Puskas, for coming after the dissection. I know Sam has to go too, and we are keeping him in there. And thanks so much, Sigrid and Dr. Taggart. A pleasure as always. Watch us. Next appointment. Submit your abstract for ICC. End of this month is the deadline. Bye, everybody.
Thank you very much. Well done, Gianluca. Thank you.
Bye, all. Thank you.